We are back with another episode of a Friends of Medicine podcast, Behind the Scrubs. I'm very excited today to have a very special guest and dear friend of mine, Dr. Leah Houston. Dr. Oren Mechanic has been on the show before, and I welcome him back. Thank you for joining us.
Thanks for having me.
Today, we're going to talk about something that's been happening over the last few years. A lot of physicians are actually leaving the medical industry, and we want to touch a little bit on why that's happening. What's the future state of medicine, if this trend continues, and what we can do as a community of physicians in particular. So this episode is kind of going to be focused more on doctors and what we can do to really recapture our profession. So Leah, I'm going to let you introduce yourself to the world and tell us a little bit about what you're doing to change the atmosphere of the healthcare industry.
Awesome. Thank you. So Dr. Leah Houston here, emergency physician, practice across the U.S. And, doctors are leaving medicine. This is not a new thing. This is something that's been going on for a while, but COVID really accelerated it. And it's really that the physician community is sick and tired of being, mistreated. There's moral injury. We're being asked to perform uncompensated administrative tasks. We're burning out. And a lot of people don't like the word burnout, because it kind of blames the victim. Some people say moral injury, but, some of the most competent, highly qualified, technically savvy physicians are just quitting, retiring early, finding side gigs and trying to do medicine as little as possible. And the sad thing is that patients are now in danger of not having access.
We have a lot of young talent out there that are very eager to get into this field, and then they experience a culture shock when they realize that the virtuous reasons they got into medicine really don't apply. This is the real world. We're dictated as to how we can treat patients, what we can do, what we cannot do, whether it's in their best interest or not, for profit. And we feel like our hands are tied behind our backs because if you say anything, if you speak, if you try to change the system, you're toast.
Am I toast?
Yeah. All right. So for those listening, it's not all that bad. First of all, you can go in. It depends on where you work. There's regional variation into, what the hospital systems are trying to accomplish. I'm sure of it. You can find a place that you're supported well. With that being said, I do think and feel that the number of places that have that, altruistic kind of mentality, through and through without looking at the bottom line constantly are probably, decreasing in numbers.
Right.
So, 10% of the workforce, considering leaving medicine, medical workforce, and especially medical students already thinking, okay, what can I do that is different than just the practice of medicine is pretty astounding.
Mm-hmm.
It's pretty high. So to Leah's point, I think that, this whole, I don't know if it's burnout. I don't think we need more resiliency training. We're sure as heck, pretty resilient during residency. I think we're good there. I think we just have to come up with systems of, bringing back that altruism, that reason that we went into medicine in the first place.
Leah, can you touch a little bit about what you're doing to alleviate some of this stress in the industry and give autonomy back to physicians? Tell us a little bit about HPEC.
Yeah, sure. We have a restriction on our right to work in the way that we want to. Many of us went into medicine thinking, oh, it's going to look like this. It's going to feel like this. And we get into it and it's not like that. And we are unable to create the life that we expected ourselves to be able to create, whether it's building a private practice or, working in an academic medical center and feeling like you're appropriately compensated and you have the autonomy to do the right thing for your patients. And, once we're in these situations, how do we leave? How do we move? How do we find another opportunity?
Yeah.
The credentialing process of me from the day that I'm hired until the day I can actually start working is a 4 to 6 month administrative nightmare.
Regardless of where you go, it's the same thing everywhere.
Right. And so it kind of keeps people like, okay, well, this is really awful and horrible, but finding another job and credentialing for another job is so much work. Like maybe I'll just try to change it from the inside, or maybe I'll try to wait it out to see if it gets better. And the fact of the matter is if we had an ability to authenticate who we are quickly, rapidly, instantaneously, we would have so much leverage to negotiate the things that we know our patients need. And so, we're building a digital identity solution for doctors that allows us to own our credentialing data, own our professional brand digitally, so that rather than these other companies that kind of like steal our professional identity, put it on the internet and sell our essentially our intellectual property and our brand without our knowledge or consent, we can own that information. And then we can leverage it to move freely and negotiate on par with, others.
You said something to me one time that really resonated and a few chords in my brain. You said to me, who creates the data? We sign your birth certificate when you're born. We sign your death certificate when you die. We create all the data in between. So we should really have a seat at the table and discuss how this data is used instead of being told what to do with it.
For sure. And, every single thing that we put in these electronic health records systems now, we don't realize that's being sold without our knowledge or consent and without our patients' explicit knowledge or consent. I mean, they're signing the HIPAA form. The HIPAA form, the word privacy isn't in that acronym for those who haven't thought about it. What it basically is, you're signing away your right to have access to your data, and you're signing away your right for them to sell your data. And so, we have been, as physicians, unknowingly essentially putting our patients' private information up for bid. And so, I think one of our members and investors wrote an article, and she called it Healthcare 2.0, the Hippocratic Oath 2.0. And this is what this is about. This next, Hippocratic Oath that we need to take as physicians is around protecting our patients from, the rent-seeking behavior on their illness.
Right.
So
this is what I love about medicine. You have smartest people, around, going to medical school, excelling, and then potentially leaving. It's not all for bad. They're leaving to then come up with another brilliant solution in the healthcare system, similar to what Leah did with HPEC, HPEC, for those that don't know. They're solving other issues, and I'm all for it. At the end of the day, you could be a brilliant emergency physician, like yourself, a trauma surgeon, but if you use those skills that you've learned, and, whether it's resiliency that you learn how the healthcare system works, the intricacies of it, then building something new that helps our patients out. That's great. That's your practice as a physician. It's just, it may not be clinical directly, but you're bringing your expertise elsewhere, which is good.
Right. What's ironic is that, for many years, we've said, we need help, we need help, we need help. We got help. And I want to touch on the mid-levels that have come into the profession now to assist us, but by proxy have been infiltrating certain things that we have always done in terms of autonomy. And now you have a situation where mid-levels are running the show in some institutions, some private clinics, etc. Is this something that's needed in the healthcare industry? Is this good? Is this potentially very risky? What are your thoughts on the mid-levels, the influx of new mid-levels right now? I personally love having them work with us, but there are some things that we need to discuss.
I think it's a little bit all of the above, to be quite honest.
Yeah.
They're a fantastic resource. The APPs are definitely providing a lot of help with access to care, immediate access to care. I do think that, the layperson, people outside of just like the healthcare system, may not realize the disparities, at least in the level of education, the level of expertise that they are developing, the training that you need to do a really good facial laceration in a 2-year-old, right? There's a lot that goes into it. So I think a little bit of all of the above what you said. There definitely is a lot of good in it. I think as we think about quality of life as physicians, they sure as heck, alleviate a lot of the burdens, right? And the answering service for a lot of doctors are staffed by them. And, they help out the doctor who's ultimately, can rest to have a full OR day the next day. So I see both sides of that token. But yeah, there are some glaring issues with it as well.
Well, because of the physician shortage and because there's not enough access, what's happened is this has created a malaligned incentive. And so instead of creating more residency spots to increase the number of physicians, because there are a lot of medical graduates that aren't getting residency spots. Yeah. So instead of increasing the number of residency spots, which would require increased federal funding through CMS, they're kind of taking this shortcut and saying, oh, well, we can use these, non-physician practitioners to kind of try to take some of the burden off. And, initially, when I first started training, the majority of people who, were physician assistants or nurse practitioners, they were pretty competent. They were essentially required to have worked for many years before they were given, more autonomy, and they worked under physicians for many years. But in today's situation, there's this rapid graduation. There's these online nurse practitioner and doctorate and nurse practitioner diploma mills where, they're doing barely 500 hours of clinical training that's really shadowing. And they're frankly just not competent to practice what they're practicing alone with no further training or supervision. And they're being told it's okay and it's safe. And unfortunately, there's a lot of death and permanent disability that's happening from this, and it's not properly being monitored and understood.
Right. This is just on a side, but did you hear about the recent fraud that occurred with
Florida?
7,000?
Yeah.
I think Florida was one of many states, something like
Florida,
7,000 plus
New York,
fake.
Ohio, New Jersey.
Yeah. Was California in it too?
I don't know.
But that is insane.
Yeah.
I wonder how long it's been going on for and how many, of these terrible outcomes are direct results of that.
Right. Ultimately, the cost savings, I don't think, are worth, getting in the way of good quality patient care.
Right. But there's the argument though that they have to pass a state exam to be able to practice, right? So how are these fake?
Listen, if I were given the USMLE step 1, 2, and 3, and I was given practice tests, questions to learn, I could have learned to take that test in maybe 9 to 12 months.
So I'm reviewing a paper back to that, like academics at heart, about ChatGPT passing the USMLE. We all saw the preprints. God. Those were the preprints. I actually, and I'm writing an editorial with one of the editors of that journal that's going to come out. And honestly, that just says that we need to change our tests, right? If you could just have someone study, there's so much. We have some medical students here that are listening, and there's so much more that goes into actually medical education than just having those didactic kind of studies. There's a lot of critical thinking. There's bioethics. There's judgment. So maybe the tests need to change, right, to accommodate for more critical thinking, and not just have some algorithm figure it out, or just 9 to 12 months of studying, right? There's so much more than you gain out of medical school.
I mean, the test is just it's just basically a tiny little sliver of a litmus test to make sure that you at least have, some of the clinical competency to be able to figure things out. It doesn't test whether or not you are ready to take care of patients by yourself.
100% agree. Yeah.
And that's why we have residency. You work under attending supervision for 3 to 8 years, depending on your specialty. And I've known a couple of residents who weren't allowed to graduate on time because they weren't ready. And they all passed every single test. They passed the test, but they weren't,
Some people peak at different times, and it doesn't mean that you're not going to be a good physician or clinician. You just need a little bit of time.
For sure.
But the whole point is, they passed the test, right?
Yeah.
And then, we've been doing this long enough that we can tell, hey, you may need a little bit more time to a resident, and vice versa. There's some residents that excel, and, even if they don't do well on the test, they're superb physicians. So I don't think the test is a good marker.
I agree.
It is a marker, of
it shouldn't be the sole,
of knowledge and whatnot. Yeah.
But it did recently take away the USMLE step 1 as a metric to getting into residency. It's now pass fail
right?
Over the past few years.
But you just use step 2 now.
Yeah.
Right?
So
for the medical students listening, we use step 2 now.
Yeah.
And is that going to create more or less, quality and disparities? Is it going to create more or less? Because now is there going to be more like backdoor handshakes between the two grandparents who one, works at this hospital and the other works at this hospital? Is it going to reduce that? It's hard to say.
I'm thinking more for like opportunities for the international medical school graduates who are brilliant. And I work with many of them. And step 1 was their moment to shine. Their moment to shine, right? In many ways, step 1,
it's true.
They crush it. They do better than a lot of, our American school colleagues, and they rightfully so, get a seat at the table. And now I think we're creating more disparities, actually with it. If someone's born internationally, goes to an international school or in their hometown and then crushes it, let's let them in, It would be an honor actually to train them. I hope there's not too much brain drain and, but if they want to go back to their country and take care of them, their own, families. That's one thing. If they want to stay here, it's an honor to have them here and take care of the patients. So
we need to increase the number of residency spots. I mean, it's gotten outrageous.
Yeah. What do you think it is? Why will they do it?
I don't know.
I think that to be honest with you, I mean, I don't want to sound like some conspiracy theorist, but I think that there is, pressure from big money to, not allow that. So
well, what's the incentive for that though? Why would they care?
Control over the flow of capital. So when you think about, I don't want to name names of companies, but there are some large pharmacy benefit managers that control the supply chain of drugs. Mm-hmm. Some of these pharmacy benefit managers are opening up minute clinics. And clinics within their so-called pharmacies, and they're hiring practitioners, and they want practitioners who will follow protocols. They don't want independent, critical thinking physicians who, are independent. They want
or who may ask questions.
Yeah, exactly. So it's all about money.
Right.
The same thing with, prior authorization situation. You hire, a practitioner who isn't going to ask questions. They're going to just follow the protocol. They're going to deny based on this protocol. They're going to approve based on this protocol. They're not going to, be influenced,
right. So what do you think a couple strategies we can do as physicians to prevent the mass exodus of doctors from the profession?
I'll always go back to develop your expertise. I'm a little jaded sometimes, but when I see physicians as well going through residency, going through the motions, they're trained well, but take a test just to pass it. Like, this is our craft, this is our expertise. Just like you may be an aerospace engineer and we all put our trust and faith in that person and their craft. We should be the same thing. So right. I think medical education, yes, we can all walk through that motion. But I say, if we develop our craft more and people realize, wow, this doctor really took care of me. It's not necessarily the doctor listened, the doctor cared. It's, wow, my heart attack was diagnosed, resuscitated. Look what happened with Hamlin for the Buffalo Bills. I mean, I was so proud of the medical staff, right? For acting so quickly. And a lot of people will appreciate, right? Yeah. They had an emergency doctor, University of Cincinnati's is nearby, right? There's so much that came into play. So I always encourage folks, dive in, develop your expertise. Being an emergency doctor, a trauma surgeon, is true expertise that a lot of other, NPPs or other practitioners can't necessarily do.
Right.
So I'd like to excel above, right? As my man.
Yeah, I mean, I'm going to say, like, I agree with that. Do the best, be the expert, take amazing care of your patients. But unfortunately, we've been doing that, and that hasn't really been enough. Like, we're being decimated. So I personally think that we need to start organizing. And we need to start working together more. We need to stop being so individualistic and start realizing, okay, we are all physicians. Yes, you're a trauma surgeon. I'm an emergency doctor. We have our other physician colleagues. We need to start collaborating and working together.
There's a unionization of physicians is frowned upon. I don't know personally of any that exist. I know they do, but people say, oh, you guys make all this money, this misconception that we're rich and wealthy. There are the few that are.
Right. There are the few that are, exactly.
So stop complaining. You signed up for this. How many times I've heard that? I've come off a 36-hour shift and I'm tired, and like one complaint of something. Well, that's what you chose. You chose that life. Like, I just feel like it's not fair, because we don't have to go through this and fight with insurance companies to get reimbursed, and or even half of the pay. It's just so many pain points along the way once you get there, that it's, the younger ones, they look at us and they see the burnout, they see the frustration, right. And there's not much excitement to look forward to. So,
and for our pediatrician and primary care colleagues, I feel for them. People they're not appreciated. People aren't going into those fields as much. And smart, brilliant medical students who would be great preventive care doctors or primary care doctors or internists aren't going in as much.
The gig is up, everyone can see it. We're burnt out. I know a lot of people don't like that term, but it's exposed, basically. You go into medicine and it's not a walk in the park life that you thought it would be. You're not going to graduate and get a job and make money and be able to buy a house and live life peacefully. It's not going to work like that, because there's so many barriers to your success as a physician now based on profit and control, that, it's really sad to see so many people leaving and not feeling like we have the ability to keep them or attract more physicians to the field.
For sure. And regarding the union thing, we do have unions of physicians. There's the Union of American Physicians and Dentists. There's CIR, which is a residency internship or union.
Well, not all programs, have access to that.
Right. And a lot of people think, it's frowned upon, but it's also, there's some regulatory things that prevent us as physicians from doing things that other union members are allowed to do. So like plumbers can strike, train operators can strike. Right. We legally are not allowed. Nurses can strike, which is very interesting because they also are providing
bedside
critical care. Yep.
Critical care. So,
the moment we even suggest that hey, there's a problem, can we have a chat? It's a big problem. It's a big issue.
You're fired. You're furloughed. You're blacklisted from ever getting a job again. I know, because of what we're doing, I've been reached out to by many physicians who you would not believe the stories. People who are at the top of their career in academic medicine and all of a sudden their careers ended because they opened their mouth about something that they don't want to hear about. So, we're not allowed to strike unless we warn people. And what's the point of that? We're also not allowed to collude to price fix. And so those are the two things that unions do to serve and support its members. And that's why it's not that we can't unionize, it's that it's not as valuable.
On that note, we're going to take a little break here to hear from our sponsors for this episode of Behind the Scrubs. We'll be right back. This episode of Behind the Scrubs is brought to you by HPEC, Humanitarian Physicians Empowerment Community. Let's hear a few words from HPEC's founder and CEO, Dr. Leah Houston.
We're building the future of healthcare, and we're asking you to join us. HPEC is restoring privacy, security, and trust to the doctor-patient relationship. We're eliminating the need for middlemen that erode that relationship while driving up costs and providing little value. HPEC creates opportunities for secure, direct patient communication that's not reliant on or influenced by third parties. We do this by leveraging a new secure technology called Self-Sovereign Identity, or SSI. HPEC allows us to digitally verify our identity as doctors in order to secure our professional right to work and to interact with our colleagues and patients directly. Once a physician has their HPEC identity, they'll then be empowered to interact with their patients in a direct and confidential way. So how does this work? You may have noticed that you can log into various pages of the internet using your email or social media ID and passwords. This is called single sign-on technology, or SSO. When we use single sign-on technology, we don't own or control any of the data that it generates. Now, in contrast, SSI can similarly be used to log in, but it's 100% controlled by you as the end user. The physician would be in complete control over their HPEC identity, with none of their information being stored on a centralized server. When we log in with SSI, we own our information, and we can't be tracked, monitored, or influenced. The data that we generate as physicians is valuable, whether it be about our patients or whether it be about our behaviors, our prescribing patterns, or our referral patterns. As a physician, I have no control over what happens to the information I've documented about my patients. Most of us currently have no choice. We've become data entry clerks. And in the meantime, we're unknowingly using platforms that capture our patients' data and then sells it to the highest bidder. They then use data analytics in order to try to find out ways to further deny care to our patients while denying payment to us for our services. This must end. Patients want more time with their doctors. They want more control over their healthcare experience. We have the chance to give that to them, and while doing so, we can also regain control over the practice of medicine. In order to make this a reality, we need to build these digital identity solutions and give them to the physician community. So that's our plan. We're creating an opportunity for you to own your future. This is our chance. Together we can make it happen.
All right, we're back with another episode of Friends of Medicine Foundation Behind the Scrubs podcast. And I'm joined with Dr. Leah Houston, Dr. Oren Mechanic, and we've been discussing the issue of physicians leaving medicine and what are some of the issues surrounding that and how we can actually prevent and alleviate some of this. And one of the pain points we discussed earlier was the whole credentialing, and it takes 4 to 6 months to be able to get your credentials to go to another hospital and all the struggles and challenges associated with that. But HPEC, your company that's working on alleviating some of these pain points, it's not only about credentialing, is it?
Nope.
So tell us a little bit about what more you do.
So we were talking about unions and how we need to, unionize, and people are discussing it. I actually disagree because of the regulatory things that we talked about. I think that, we need to organize, we need to collaborate, we need to, if doctors are going to leave their current situation in medicine, how can we keep them in the practice of medicine? How can we keep them wanting to practice medicine? So, if you're leaving a situation, most of us really love practicing, but we don't love the administrative burden. We don't like how we're being treated by our employers. We don't like, all the prior authorization nonsense. So how do we create situations where physicians can be independent, can be and stay independent,
Right.
Insurance companies essentially control the referral networks. So how can we build a physician-controlled, physician-centric referral network through this solution? And so if you own your professional brand, you can also essentially build out a Rolodex of other physicians who also own their professional brand. You can find ways to collaborate. You can build referral networks. You can, know who the expert is for this very specific particular thing.
And for our listeners who may not be aware of the current system, in network, out of network, you're a patient, you want to see your doctor, you're a physician, you want to refer to the expert for this particular condition, but you can't because the insurance is not in network. Can you explain a little bit just for the basics?
For sure. So, there's a spectrum of independent versus employed physicians. So the independent physicians, some of them have completely unplugged. I'm putting in a plug for the direct primary care community. There are, groups of physicians who have said, you know what, I'm opting out of Medicare and Medicaid. I'm not ever taking insurance. I'm going to give my patients a very fairly priced membership model, $50 to $150 a month. And
concierge type.
It's not even concierge, because concierge physicians often also take insurance, and, completely unplugged. And so these, kind of like renegade physicians are like, I'm not going to allow these third parties to influence me. So they open up these private practices. They give the doctors their patients their cell phone number. And, the only issue is what happens when your patient needs a neurosurgeon or a cardiologist, or what happens if you want to take a vacation, So, but they're building out these networks all over, the country. There's, thousands, I think, of direct primary care doctors now. So that's one end of the spectrum, the complete unplugged, cash only situation. But then the other end of the spectrum is the employed hospital-based, only get paid through insurance, in part because your patients are primarily critically ill patients who require, ICU, surgical care, require care coordination amongst multiple teams. And so, yeah, that's the spectrum. But, even the doctors who are currently employed in the hospital model or in any kind of other corporate model, in the olden days, those people also had their own private practice. So they just had privileges in the hospital. They also had their private practice. They weren't completely owned by that end of the system. So if we can create opportunities for doctors to have independent private practices where they can coordinate care with some of these direct pay doctors, then we can kind of create a little bit more autonomy and be encouraged to stay in medicine and to no longer just leave altogether, which is what's happening.
Right. So tell our listeners where they can get more information about how they can join your community of HPEC.
Awesome. So HPEC is at hpec.io, and you can log into the app and join today. And it's free for all physicians in the US. It's an identity app, so we verify identity. And you can follow us on social media. I'm at Leah Houston MD across all channels. And I'm on Twitter and LinkedIn a lot. And just join. There is a lifeline being thrown out there, and you can grab onto it and join us and consider the possibility of fixing this.
Awesome. Dr. Mechanic, I want to touch base on one last thing before we wrap up. So, we're talking about physicians leaving medicine. Some just want to leave. They're done and they want to go on to something else, The passion is not there anymore. If they've served their time. What advice would you give to someone, that just wants to pick up and leave that, but they still want to maintain that lifestyle? What options are out there? That
lifestyle is the high earning physicians, because there's this dichotomy in medicine that I think is unfortunate, but is a reality. So first and foremost, out of complete transparency, I've cut back shifts, over time. I am 10 years out of med school, I think, something like that. And I've started just to cut back a little bit because I'm realizing that, our value is in the hospital, taking care of patients, but also helping in this whole like innovation of healthcare, right? Let's get things moving. I talk about modernizing our clinical care. And that does take some, a capable physician like many of our listeners here to actually step out and say, hey, how can I help you? Right. The Amazons of the world, succeed. Yeah. Right. And so I've always said clinical. I always, to my mentees at least, because that means that they're oftentimes younger than me, stay clinical, like stay active, develop your craft, but then start thinking about, other ways that you can actually help out. Expert and witness. I think we've talked about that. There's, consulting opportunities. There are so many startups out there doing fantastic work, and you could just be a lifeline for them in many aspects. Just help them out. It may not mean that you would get paid the same as clinical medicine, especially for the high earners, but at least you can feel as fulfilled seeing some, initiatives spread across, the country. I've said this before, I came from more of like an academic background. I like studying stuff and nerding out. And so like part of a company that I've delved into has really tackled, it's called eMed. And we just got an NIH grant, right? And that is pretty cool for, a company to actually partner with the NIH and then an academic institution to actually we're trying to bring telehealth to people's home, COVID care. And so you can still actually use all the skills that you've learned over time in med school and, residency afterwards. When I used to study things that I was like, all right, this is like, I'm studying an observation unit for syncope and nerding out on that. But okay, how do I take that and actually, join a company that may be thinking about researching other things, right? Yeah. So I think that there are a lot of parallels to industry, and people should at least reach out. Right. I'm happy to help, get to know what else is out there. There's a lot.
Yeah. So let our listeners know how they can reach you.
Sure. So I'm primarily on LinkedIn, Oren Mechanic, just first name, last name.
We'll put the link at the bottom of this episode so you guys can check him out. Personally, I advise my students and residents to just keep an open mind. Don't be so blinded into that specific specialty 100%. Keep an open mind, especially medical students. They go in saying, oh, I want to be a neurosurgeon. That's all good and great. I wanted to be a neurosurgeon once. I went into residency and I did a few years and then I realized it's not for me. And that's okay. Keep an open mind. Sometimes you may go into something and you may become the CEO of a tech company that deals with that. But, you have to have an open mind, explore different areas, network with people outside of medicine, go to networking events, come to our events, Friends of Medicine events, and meet these doctors that are doing great things outside of their fields. It's not impossible. Just because you're a physician in a specific field doesn't mean you can't be an expert in another field. Right. We're pretty smart people. I'm going to say that out there. We're smart, and we need to be able to network in other industries, learn what they're doing, collaborate, and make changes that can actually help us in our own industry. Yep. So that's my advice to everyone. You guys know how to reach me. I'm Trini Trauma Surgeon on Instagram, and our foundation is friendsofmed.com, or on Instagram, friends_of_medicine. And I encourage you to click the link below, come find out about when our next event is. Meet Dr. Houston, Dr. Mechanic. Click the link below. And I look forward to seeing you guys. Hopefully we can host you on the show one day, or one of your mentors. If you have any ideas for us, reach out to us. And we look forward to seeing you in another episode of Behind the Scrubs, Friends of Medicine podcast. Thanks, guys. Appreciate it.
Thank you.